Good afternoon, everybody. We're here to do this today. Chapter 19, Neurological Emergencies. Some things you need to know. I always skip over those. We're going to go over some anatomy and physiology of the neurologic system itself. We're going to talk mainly about seizure, stroke. We're going to talk about what status epilepticus is, and we're going to go over some headache stuff. Some facts for you. I don't know if they're true or not, but you can verify those if you want to look at the CDC. CDC is a good place for information for death and illness, stuff like that. Seizures, they're going to talk about this, and we'll go into this more in depth, but they can be caused by a whole myriad of problems. You could have a recent head injury, a brain tumor, could be a metabolic problem, or you could have just a pre-genetic disposition to have them, like epilepsy. One of the things that we are worried about is altered mental status. We're usually looking for the reasons why a patient has altered mental status. It's not normal for a patient to have an altered mental status. Usually indicates something is going on, and it is up to us typically when we are called or when 911 is dialed to go out and figure out why they are altered. It could be a whole myriad of reasons, whole host of reasons why. But it does fall kind of under like a neurological problem because they're no longer technically awake. They no longer have a solid neurological status. We're going to talk about the central and peripheral nervous system. We're going to get into all that. So here we go. Central nervous system. Remember, the central nervous system is comprised of the brain and the spinal cord. It is basically the super highway for the brain to get all the information out and down and out. How we get it to our specific targeted areas is a peripheral nervous system. Now, how that is done, I cannot tell you. My knowledge on this is very limited. I just know what I've learned and what I've got so far. So I apologize for not being the expert, but what I can tell you is that the central nervous system, brain, spinal cord, and peripheral nervous system is going to be composed of your cranial nerves. We'll talk about what those are, your spinal nerves and the peripheral nerves themselves. All right, so the nervous system, how it's broken down. We go back to the CNS. You got the brain and the spinal column itself, or the spinal cord. That's your central nervous system. There's no argument, nothing we can say about that. That is just simply what it is. When we go in the peripheral nervous system, you have different types of nerves that do different things. One are motor neurons. Your motor, it basically causes movement or causes things to be done. Sensory is the input. So basically what you have in your peripheral nervous system is you have output and input. Output is basically your motors and signals being delivered to the body to tell the body to do something. Sensory is like the information collection. It's like, all right, I feel it's hot, it's cold, what should I do? Here you go, let's tell the brain what we've got, and then we can make a decision from there. Sensory is cut and dry. It just feels, sends signals back. The motor stuff is different. Somatic, the somatic nervous system. Somatic controls voluntary muscle movements. Me moving my hands is a somatic nervous system function. So that is something that I control. It's something that I want to do. I think to do it, and then it happens. The automatic nervous system, or the autonomic nervous system, controls involuntary responses. It basically has to do with your breathing. You can't control. We have discussed that before, where you can think to breathe, but you can't think for your heartbeat to do things. Also, regulating your metabolism. What they really narrow it down into is a sympathetic and a parasympathetic division of that. The sympathetic division is your fight or flight. It basically it recognizes danger, or you recognize or visually perceive danger. You see the danger. You quickly jump into action, releases adrenaline into your system, which is the adrenal gland is on top of the kidneys, and that's why it's your fight or flight. You'll make the decision to either stay and fight, and you get revved up, your heart rate's jacked up, your blood pressure's up, you've got an adrenaline dump to be able to go ahead and fight, and you feel like you can fight and take care of that, or flight, you're going to run the hell away. And it's going to give you the bump or the kick you need to get and run as fast as you possibly and physically can. On the flip side of that, you have the parasympathetic. It basically means rest or digest or feed and breed. It's basically where the heart rate slows down. You're really comfortable. It's kind of like the reason why whenever you eat, you want to just You want to sit. You don't want to get up and do anything. That's because your body is saying, whoa, we just ate. Let's just go ahead and digest this meal. Let's just stay right here and let's do that. So that's the two divisions of the autonomic nervous system. So it's a lot to take in. It's a lot to understand. But once you kind of pick this up and realize that you got your central, your brain, your spinal cord, the peripheral systems, you have the motor, which it doesn't matter whether it's you control it or it's done on its own. The sensory is just simply information in. But under the motor, you got, like I said, you've got the somatic where you control the movements and the autonomic where you don't control it all. So, and then you have your sympathetic and parasympathetic divisions under that. So a lot of information to take in, a lot to look at, but that's how that works. So we're going to start with the book starts with building from the brainstem and looking upwards and outwards. So what we're going to start with is the fact that the brainstem controls a lot of things and is part of the autonomic nervous system where you don't really control it. Breathing, even though you can override your breathing, but just to sit there and be reading a book, you're not thinking about breathing. Breathing is took over by the brainstem. Your heart beating, usually swallowing, blood pressure, pupil constriction, and adjusting to how much light is coming in, and your pupils will constrict down or dilate out depending on how much light they can take in without hurting your eyes. So a lot of the stuff is just done automatically for you. It's kind of nice. It's kind of like having an Alexa. Alexa, you basically just have that feature there, and it just does it for you and don't even have to ask for it. So it's a nice feature. So a lot of things that we don't have to control to actually be able to enjoy living and creating and being a human being. The cerebellum. So let's go back. Cerebellum is this little portion right underneath here. It is underneath the big portion of the brain. The cerebellum, it says, it's kind of generic. It says it controls muscle and body coordination. That is very true. Because there are things that you do, even like psychomotor stuff, even me having you guys do lab and do it so many times, is to basically get it to become and commit it to muscle memory. Walking is muscle memory. It's just things that you can do where you decide that you're going to do them, but you don't have to sit there and worry about trying to actually be coordinated. Imagine if you had to try to think about walking every time you did it. It'd be kind of a coordinated event. The cerebellum takes care of all that. It takes care of all the things, all the movements and repetitive stuff that you've done over and over and over again, and it makes it so you don't have to think about it. I think I've said this before. Have you ever been driving in your car and you get so lost and deep in thought, you come to, or you have a central awareness of where you are, like you drove home and it's a 30-minute ride and you're thinking about your day at work, and yet you realize that you're home and that you have to get out of the car and you're turning the car off because you've done it so many times driving home on that path. It's become, quote unquote, second nature. That's your cerebellum. That's your cerebellum taking over and allowing your brain to actually have cognitive thought. If something were to change, you were to see a yellow light that you're not used to, or a car pulling out in front of you, it would automatically kick back over into conscious thought, and your brain would have to readjust and figure out what to do from there, because that's not part of the normal routine. So the cerebellum is pretty much like the coordination, like, oh, this is routine, we do this over and over again. It's kind of like that movie Click. It's just all the stuff that you don't want to deal with, your brainstem and your cerebellum just take care of it, and allows you to have conscious thought, which is done by the cerebrum. It's divided into right and left hemispheres. You've got two halves of it. They talk about kind of what the control. I've actually put some more slides in, and we're going to talk about that. One thing I do want you to understand, if you're looking at the brain, this is the left side, this is the right side. Patient's face is here, back of their head is here, spine is here. What you have is right and left sides, but you have to understand that the right side controls all of the left half of the body. If you're to divide yourself in half, your right brain controls the left side of the body. Your left brain controls the right side of the body. It crosses over as far as movement. Movement, it crosses over once it starts coming down into the brainstem. It's really odd, really weird. I don't understand why that happens, but it does. That's how you know if we get into a stroke here and they have left-sided paralysis, the left side's weak, they're having more than likely on the right side of their brain some sort of stroke or an issue. that's why that's important. So when we talk about the cerebrum, we're talking about the frontal lobe. You've got a motor cortex and a sensory cortex. Those two, sensory and the motor, are still part of the frontal lobe. You have the parietal lobe, the temporal lobe, the occipital lobe. There's your cerebellum, and that's your brainstem. In reference to the frontal lobe, this has to do a lot of with your thoughts. Temporal lobe has to do with a lot of your hearing and your hearing. Occipital lobe has to do with vision. And parietal is kind of like your perception. You're making sense of the world in and around you. This is where you're creative up here. You've got your movement and your sensation here. You've got, again, like your perception of the world, vision, and your memory, language, and hearing here. All right, so everything travels through the nerves. The nervous system is the superhighway for the main computer, which is your brain, to send out signals and have things get done. And not only to have things get done, but to get information back from the outside environment. Up to this point, we pretty much have told you that all the nerves come from the spinal column. Not exactly true. There are 12 what they call cranial nerves. There are 12 of them. Now, mind you, 12 on each side. So technically 24. You have 12 on each side. And these 12 cranial nerves are paired, and they pretty much follow the same path, and they innervate and control or are responsible for the same sides of like the face, the head, down into the neck, the tongue, and the vagus nerve even goes so far down into your abdominal cavity and can help control your diaphragm and some digestion. So, yes, like probably the majority of the nervous system comes from the actual spinal column, the spinal cord itself. But again, you have a pair of 12 cranial nerves. I'm not going to make you memorize them. I had to memorize them in paramedic school, not in EMT school, but I was made aware of them. But this is their names. They're actually Roman numerally numbered. So if you don't know your Roman numerals, you probably should learn them. But this is what they're responsible for. And as you can see, the vagus nerve comes down, and there's an accessory nerve that come down and help with breathing and digestion. This is, again, the Roman numerals on this side, the name of the nerve, and what it helps control or sense. Because some of them are motor, some are sensory, and believe it or not, some of them are both. But I'm not going to make you memorize what those are. I just want you to realize that there are 12 cranial nerves out there, and they exist, and not everything comes from the spinal column. All right, so at each vertebrae, 2 nerves branch out. And it's kind of annoying. The name of the nerves are typically named after the spinal region and the number that they come out as. In the cervical column, they actually leave out at the top of the cervical vertebrae itself. So C4 is at the top of C4. C5 is actually between C4 and C5, but it leaves out at the bottom of C4, top of C5. There is a little kink in the work, the C8, and we'll talk about C8 here in a minute. One of the things I do want you to realize, though, I'm going to back up, is that depending on where your pain is localized, if you do have pain, and that sensation of pain is being relayed back to the brain, you now know what area is being affected, or what nerve. Because sometimes you can actually pinch a nerve and have the nerve that's being pinched, you have pain all the way, radiates all the way down to certain areas. That's why they're able to tell, like, if by the pain of what you feel. Like, there's some people that have something called sciatic nerve pain. Well, there's the sciatic nerve, but they know that based on which side being pinched and stuff like that, they can figure out where, if you have some sort of herniated disc or an issue of that nature. So they're able to tell by the pain that you feel, the location, and what nerve it's probably being affected. So when the nerves come out, if you can imagine that you have your vertebrae here, they come out and they innervate, or they come out in ganglia. They come out individual, then they actually bunch back up together, which is kind of weird, kind of odd. But it just shows you the complexity of the nervous system itself and what happens with the nervous system. So you actually kind of have sometimes remember your referred pain? We talked about referred pain. That's typically why sometimes you will have and feel referred pain. It might actually stimulate on one nerve and then be set down to another, so you think that you're having pain. in an area where it's not being affected whatsoever. It's almost like the shared nerve where they all come together. It may branch out somewhere else. Well, you're feeling pain on one, so you're feeling pain, like, say, in this entire nerve, but notice it branches out somewhere else, and maybe thinking, or you feel that there's pain along the whole entire nerve itself. So that's how you get the referred pain. It's the fact that they're not just individual nerves that come out. They actually come back out, bunch up together somehow, some way, and they cross-relay to each other, which is really interesting. But that's why you can get the referred pain, and that's what I wanted you to take out of this slide. All right, so you've got the neurons themselves. We're going to talk about the actual physical, like we're going to get down to the cellular level of what the nerves are made out of. So in the neuron itself, the actual cell of the nervous system, and we're going to show you one type of cell here. One type of cell. There are different variations of nerve cells. So the one that you're seeing is just one variation of the nervous system itself. There are a dozen, if not more, types of nerve cells, all right? But there are three basic parts. You've got the body, the axon, and the dendrites. So let me just show you what we got. Okay, so what you have is you have an electrical impulse, or a quote-unquote electrical impulse. It's going to be generated, and it's generating here in this nerve. It starts off in the body, okay? So it starts off down the body, and it's fired down the small, skinny-like structure here called the axon. And what happens is it branches out down here at the end of the axon, and it's something at the end of these branches is called a synapse. So in the body, you still have the nucleus. The nucleus is still where you've got all the actual core of the cell, what needs to, what the DNA, the RNA, and then, of course, you have the rest of the body of the cell itself. And again, the signal is going to travel down this axon. So when a signal is generated, whether it be sensory, back up to the brain, or from the brain back down to the body of some sort of motor response, it's going to start in the body and then work its way down. The synapse is where all the action takes place. We're going to talk about that. So in the synapse, believe it or not, electricity is not fired. And also, believe it or not, the nervous systems aren't actually touching. There is something at the end of the synapse called the synaptic cleft. There is this small, microscopic, small, teeny, little itty-bitty cleft. There's a space between the end of the synapse and this. Either it's going to land out on the target cell, which can be muscle, any tissue, any cell that you can think of in the body that is not a nervous cell. Like it could be the adrenaline gland, it could be the stomach, it could be anything. That's called the target. That's called a target cell. Or it can go to another neuron, which is going to have at the end of it, let me back up right quick. It's going to have something called a dendrite. Let's see where they don't show that. They don't show the dendrite. But basically the dendrite is the receiving end of the body. These are all dendrites out here that would receive information. It'd get processed through the body, sent down the axon, and then out to the synapse. And again, there's something called the synaptic cleft. The nerves technically don't touch anything, which is kind of weird. If you think about it, it's kind of hard to wrap your head around the fact that you actually are not touching anything with your nervous system. But what happens is there's something called neurotransmitters. And depending on the signal that's being sent is going to depend on what neurotransmitters are going to be sent out and across. So all these neurotransmitters are actually in vesicles. They're in these wrapped up in these little small balls. And what happens is the signal is sent. It hits the vesicles. The vesicles then come out and across and release out here across the synapse, across the synaptic cleft. The vesicle opens up, lets out the neurotransmitter, and remember, even in, whether it be a dendrite, the end of the dendrite, which is another cell for the nervous system, or the actual target tissue that it's trying to reach to stimulate. Remember, all cells have the receptor sites. They're not just nice, smooth, and round like you see in the picture. They have all those different receptor sites. So depending on what neurotransmitter has been told to release, it's going to depend on what it fires across. And then it has all the receptor sites for all the different neurotransmitters, and it's going to pick out what's being sent across. And based on the neurotransmitter, it's going to tell it to do some sort of function. This is about as deep as I get, guys, and I'm sorry. It does get deep, and it gets deep really quick, but that is how the nervous system works. It is not, there is an electrical generated impulse set down. But it winds up being that the neurotransmitter, it's not electricity that gets sent across. It's a neurotransmitter inside of a vesicle, gets stimulated, pushed forward to to the end of the synapse, opens up synaptic cleft. And to make it even more confusing, when it's fired across, it does what it's supposed to do. It hits the target receptor. It stimulates the next cell on, and then it releases the neurotransmitter. And the neurotransmitter comes back up across, gets picked up back up, and put into a vesicle and held again. It's done. It's done, and firing, constantly and very, very quickly. With every movement that you have, thousands of neurons are activated, and the neurotransmitters are released and reuptaked again. So it's the reuptake. It's very. It's kind of confusing. It's hard to get your head around. If you have any questions, you guys know how to get a hold of me and ask me. There's one more thing that I want to point out. Some cells actually have something called a myelinated sheath. They're myelinated, which means they have some sort of protective covering. It's kind of like having a wire with plastic wrapped around it. Now, it's obviously not a wire, and it's obviously not plastic that's being wrapped around it. But this is called a myelin sheath. Now, your book didn't talk about it, so I really didn't stress it, but I want you to know that there are some nerves that have myelinated sheaths. It's very important because there's something called MS, which the book didn't talk about either. But if someone has MS, myelinated sheath gets attacked by your white blood cells, and you start losing transmissions. But anyways, I just want you to know that's how this works. This is kind of a closer up drawing of it, of how the vesicle comes down, it opens up, the targets pick up the actual receptor that it's looking for, and then, believe it or not, it does what it's supposed to do, releases the neurotransmitter, it comes back across the synaptic cleft, and then a reuptake pump is put in, pulls it back in, and then it forms another vesicle to send it on. And again, that is about as deep as I get, guys. I really don't understand anything past that right there. Put this slide in there for you. These are some of the neurotransmitters that I'm aware of. I don't know if there's any more than this, but I know that these are the major big bad dogs that are used. We're going to talk about disorders and things of that nature. This is kind of an introductory slide to get you ready to be able to start talking about the pathophysiology of what happens. All right, so now the big dog. The big dog, there's two big dogs in neuro for us and what we care about. It's going to be stroke and seizure. Stroke is an interruption of blood flow to the brain, and there's two ways that happens. One, you get a blockage. Two, you have a rupture of the vessel itself. And we're going to get into that. So either way, you lose that blood flow. Either way, that means that the oxygenated red blood cells are no longer getting to the blood tissue. And remember, the two things that our cells love, and our brain especially love, are glucose and oxygen. So here we go. All right, so they say there's three things really of how the blood flow is interrupted. I'm actually going to get into this. I don't like the slide, but here we go. So you can have what's called an ischemic stroke. Ischemic. Remember when we talked about cardiology? Ischemia was inadequate oxygenation to a specific region or specific cells. And if you look at this picture, depending on where the clot is caught up and it blocks, if you can have a clot that actually gets thrown into the vascular system, and if it winds up going up the carotid arteries into the brain, depending on where it gets hung and lodged at, is how much damage or how much ischemia it's going to start causing. Now remember, ischemia can be reversed. Ischemia can be reversed, but the same thing was they say time is tissue, time is muscle. Same thing is true here. Some of the problems that they're having, though, when you do have these strokes is one of the things you need to ask, and we'll get into that in your assessment, when's the last time they were seen normal? The bad part is you might have people that were seen normal that go to bed at like 8 o'clock at night, and they wake up at 8 o'clock in the morning, and now they have these stroke-like symptoms, so you don't know how long this has been going on. They are done a lot of research here in the past decade about how they can reverse strokes and how long they might be able to actually do a thrombotic stroke or an embolism or embolic stroke. They used to say if it was a 4-hour window and then they couldn't do anything, it wouldn't matter. There's going to be tissue death to the brain. Now they've upped that to like 6, and some are arguing 8. to restore some function back. So there's different ways. But so for an ischemic stroke, it says 2. There's actually 3. There's a thrombus. It can be an embolism, or you can have atherosclerosis. I'm going to talk about that here right now. So either way, with ischemia, you're going to have some sort of blockage. Something's going to happen. Atherosclerosis, again, is just the fatty deposits from like hyperlipidemia, having too much fatty proteins in your blood, and they start building up along the arterial wall. That's actually kind of a genetic thing. You can't outrun your genes. Some people are just predispositioned to have more fatty tissue buildup, or it could also be a diet thing. You eat a lot of fats and your body can't process them all, and they start lining the wall. That's what happens. So it just so happens that you can have it in your heart, and you can have it also here in the brain. Another thing that can be caused is just a thrombolic stroke. A thrombus is just simply that, a blood clot. That is what a thrombus is. It is a blood clot. So you have a clot that's somehow formed. It's typically formed maybe like an AFib, and it gets thrown out to the body. It typically gets kicked up into the carotid artery, and then it winds up lodging itself in the brain somewhere. That's how you can have a thrombolic stroke. You can also have something called an embolic stroke. It does not have to be a blood clot, although they define an embolic stroke to throw in a thrombus. So embolic stroke's kind of the big umbrella. Thrombotic stroke or thrombolic stroke is basically just a clot that's formed by itself. An embolus can be a debris. So let's say you start an IV on someone, and when you're starting your IV, you mess up and you accidentally shear off a piece of the small little piece of plastic. That becomes an embolus. It's a piece of foreign material, and if it's big enough, it can go ahead and get thrown, and it more likely wind up in the brain somewhere, or a blockage somewhere. It also could be an air bubble. You can also do that by accident through an IV. Fatty deposit. Women giving birth to childbirth, if they have a tear in their vaginal area, and they accidentally tear into an artery, and they have like any of the amniotic fluid get into there, that's considered an embolus. So anything can be an embolus. That's what they're saying here. Anything can be an embolus, but if it's going to be a clot, it's going to be a thrombotic stroke. So some of the signs and symptoms that you're going to have is you're going to have some sort of you may have a loss of consciousness. It doesn't always start with a loss of consciousness, but you might have complete paralysis on one side, or it can be just as little as some numbness and some tingling. It really honestly depends on where the clot gets thrown to and what area of the brain it's affecting. Remember, the cerebellum has to do with just repetitive psychomotor movement. If you have somebody that can still talk, think, and answer all your questions, but they just can't get up and walk, and it's all of a sudden it's new, that's not the classic signs and symptoms that we're used to when we think stroke. We think, it's got the facial drooping, the arm drooping, slurred speech, those are the classic signs and symptoms. Yeah, sure, that's great for cerebral stroke, but you can actually have a stroke in the cerebellum. You can have one in the brainstem. It all depends on where it winds up, but typically it winds up being in the cerebrum itself. So that's what you need to be looking for. All right, now on the flip side, hemorrhagic stroke. Hemorrhage meaning bleeding. You can actually have a blood vessel that ruptures inside the brain itself. So there could be an actual spillage of blood into the cranial cavity. This one, you won't have the slurred speech typically. This one, you're not going to have any of the signs and symptoms. They may start that way, but then they're going to go completely unresponsive, and they're probably more likely going to code, meaning die. Again, here's the difference. You got the ischemic stroke is a blockage. That's where you're having the ischemia. Hemorrhagic is where there's a rupture and there's a loss of blood flow. So the first thing I want to talk about right quick is, we usually cover this in shock trauma, but we didn't start with that first. The cranial vault. The cranial vault is the space where the brain sits. And let me tell you, this is a finite space, meaning that there's only a limited amount of stuff that can be in there. You have room for the brain and the CSF, which is cerebral spinal fluid. You have just enough room for all of that. There is not enough room to add in a bunch of blood or to add in some swelling. If the brain tissue gets infected or inflamed, there's not enough room for that. You have this finite space, this limited space of where the brain is happy, comfortable, and it sits and it's protected, nice and neat. But you cannot put anything else in that space. You are limited. If you were to start trying to introduce blood and start putting more stuff in there, and it's typically blood, sometimes it's cerebral spinal fluid, or it can be the swelling of the actual brain tissue itself, you're going to have something called ICP. Not insane clown posse, but increased intracranial pressure. What happens is that you start building pressure up in the brain. Remember, it's a finite space. It cannot go anywhere. So you start putting more and more stuff in there, the pressure is going to build and it's going to make it tighter. The cranium is not going to rupture. So therefore, it's going to hold a lot of pressure. So what happens is that you start shoving and moving brain tissue and moving it and trying to push it up out of the way. That's called herniation. We're going to get to that too. In having the ICP increase inside the cranial vault, you're going to start damaging not only the area of the brain is now affected, but you're going to start damaging the whole entire brain, because what you're doing is you're starting to squeeze the brain and push it and squeeze it out. Part of the problem that you're going to have is you're pushing the blood back out. So now the heart has to generate more pressure to get more blood flow to try to pump it into the brain, because all the brain is recognizing is it says, oh my God, we're going to have to jack the pressure, because the two things that I love the most that come via the blood system, become the cardiovascular system, my sugar and my oxygen, I'm not getting. So something's wrong somewhere. So it still sends out signals to increase blood pressure. So you'll have a patient with most strokes that is going to be severely, severely hypertensive. So they kind of have some different levels of this, but when you start having this shift and this herniation, you will have a patient become altered. I ran a call where a patient was working, he's 40-something-year-old male, working, setting up in the summer, school's about ready to open. I was on clinical, and he said, oh my God, honey, I just felt something pop inside my head. He sat down and goes, oh my God, I'm dying. He had an impending sense of doom. And he said, I'm dying. And sure enough, he wound up somehow he ruptured a blood vessel inside his head, and he deteriorated very, very, very quickly. Very hypertensive. He was altered like almost from the get-go. It took us like 5 or 6 minutes to get there, and he was altered already. Snoring respirations. It was pretty bad. We do talk about herniation. Herniation is basically when the brain is squeezed and moved and tried to be shoved somewhere else. That's called herniation for the brain. There's different levels or different types of herniations. I'm not going to really get in and try to make you memorize those types, but just understand that you can also have brain matter herniate out through a open hole, i.e. a gunshot victim. If it has an entrance and an exit wound, even if it's got an entrance wound only, and this stuff and the brain tissue starts to swell, or there's bleeding and it starts pushing, you will have brain matter start coming out of the hole. It does happen. All right, so we talked about stroke and what causes it and some of the signs and symptoms. I haven't talked about signs and symptoms. We will get there. But there's one thing, corona. One thing you need to understand is there's something called a TIA. It's called a transient ischemic attack. And a TIA is classified as stroke-like symptoms. A patient will present with stroke-like symptoms. They will act like and look like they are having a stroke. But what happens is, within 24 hours, those symptoms will go away. Now, 24 hours is a very long time. Typically, the TIAs that I have seen usually resolve themselves in about 15 to 30 minutes. It's very odd and very weird, because you will show up on scene and you will have a patient that is having a stroke. So you start trying to work through your stroke protocol, start trying to do what you can for the patient, put them on oxygen, get an IV, because ultimately there's nothing really we can do for a stroke patient except get them to a stroke center. So that being said, You're trying to work through your stroke algorithm and trying to figure out where you can go, if you need to fly the patient, yada, yada, whatnot. And then all of a sudden, the patient starts moving their arm. And then you notice that their facial drooping is not as bad. And then that's what clues you in. They're probably having a TIA. Now, with having a TIA, that means that the big one is coming. That basically means don't let the patient say, "Oh, I had a TIA. Oh, okay, I get it." So it's a mini stroke. That's what they're called, mini strokes. So I had a mini stroke, so I'm okay, I'm good. No. It's kind of like sometimes like earthquakes. I grew up in California. Sometimes you had small little ones before you had the major big ones. So not always, but sometimes the small little ones are going to give away that there's something wrong. So if you get a TIA patient and all of a sudden they're alert and oriented and they want to refuse, you need to explain to them that, you need to get a workup. You need to go to the ER. You need to be evaluated. You need to see what's going on because the big one is coming. So some of the classic signs and symptoms of a stroke, facial drooping. It'll be on one side typically. You'll have like the facial drooping, weakness or numbness on one side, decreased absent movements and sensation on one side. Ataxia. We go back to the cerebellum again. That's control of movement. Ataxia means without being able to have a steady gait or be able to walk. Can't walk very well. Some vision losses, stuff like that. You also have some dysphagia, difficulty swallowing. Aphasia. They won't be able to speak. I'll have to fix the slide. It says can't speak. You have a decreased level of consciousness. They'll have slurred speech. They'll be trying to talk, and then you'll actually have some patients get very upset. The patient still can think. They still can cognitively, most of the time, think. They just have a blockage to a certain part of their brain that it's being affected. The rest of the brain is still working properly, but they're still having those issues, depending, again, on where the blockage is. One thing your book didn't throw in there, but I'm throwing in there, is the Cincinnati Pre-Hospital Stroke Scale. Basically has to do with droop, drift, and speech. They put it into something called Act Fast. This is for the layperson, but I still want you to know this. If you want to remember it by FAST instead of the Cincinnati Pre-Hospital Stroke Scale, I don't care. But it has to do with facial droopage. On one side, you'll have the facial droopage. Drift, arm drift. Basically, what you'll do is you'll say, for this, you'll say, smile for me. And they'll smile. On one side of their face will smile, and the other side, there'll be nothing. Drift, arm drift. What you'll do is to tell your patient, put your arms out, hold your arms up, upside down, close your eyes, and then you're still holding them. And then you'll let them go and say, all right, hold your arms up. And then one will just pretty much either gradually fall down, or it'll just fall really quickly. Speech. You'll say, all right, do me a favor, tell me this phrase. I've used the old adage phrase of you can't teach an old dog new tricks. Believe it or not, people having a stroke have a very difficult time saying that. And the reason why they added in for fast was time, call 911, which is us. Or for us, time is of the essence. Remember I said they've done some research, but typically the onset for a stroke that I was taught was 4 to 6 hours. You have to get them to get clot, if it's a true embolic or thrombolic stroke, to get something called fibrinolytics, which is a clot buster material, into the body to bust up that clot and restore blood flow to that part of the brain. There's something called a MEND exam. They didn't have this in here either, but MEND, it basically is a checklist. Some ambulances actually have them. It just adds on and incorporates more into the Cincinnati Pre-Hospital Scale. This is kind of, this is what it is. It's a little more in depth. I'll let you look that up. You can look up MEND exams if you want to, but just for me, as far as all I care about is whether you be able to recognize a stroke or not, is the Cincinnati. I want you to know drift, droop, and speech. Arm drift, facial droopage, and can't teach an old dog new tricks, slurred speech. That's what I really want you to know. They talk about where in the brain that they could be having issues. I really don't care. You're not going to be able to do anything with this information. All you're going to know is that it's going to probably be, if it's on the right side, it's left brain. If it's on the left side, it's right brained. But that's not up for you. They're going to get a CT. If you call a stroke alert, especially to a stroke center, you're actually going to be wheeling the patient into the CT room, not an ER bed, but right into the CT, helping them transfer the patient over and do a quick CT on the patient's head. So that's the new standard of care. There are some things out there that can mimic a stroke. One is hypoglycemia, which means low blood sugar. You can have diabetic patients where their sugar drops so low that you need to check a blood sugar. If you do not check a blood sugar and you try to transport a patient, you'll do more harm than good. Because the one thing that you could be able to do is give them some D50 or some oral glucose, depending on whether they're alert and able to swallow. And also, you'll look like an idiot. Where I live up in Towns County in Hiawassee, Georgia, we fly a lot of stroke patients out. We don't mess around. We can't get them fast enough to a stroke center. So one of the things and you'll feel like an idiot, and I've seen it done. I've been part of the crew that's had this done, is did any of you check a blood sugar? No. Well, thank goodness it wasn't the blood sugar. We just automatically saw it and thought stroke, called a helicopter. But let me tell you, you'll look like an idiot if you don't check the blood sugar. One of the things you want to tell the nursing staff or whoever, or when you're calling in your radio report, or you're calling over into a helicopter, whoever you're transferring care, hey, blood glucose is such and such. Now, if it's low, give some. If it resolves the symptoms, fantastic. If it doesn't, then you're still dealing with a stroke, and you were dealing with some hypoglycemia. Postictal state, that's after seizure. We're actually going to get into seizures here in a minute. And subdural and epidural bleeding, that can mimic a stroke as well. But we'll get into that when we get into shock trauma. We're going to worry about that. Subdural and epidural bleeding, we're going to get into that when we get into shock trauma. All right, so seizure. A seizure, especially the classic seizure where you see somebody fall, tense up, and start shaking, that is a huge electrical discharge of the brain. That's basically the brain says, screw it. I don't know what's going on, but I'm going to fire everything all at once. Everything is going to get fired. The patient will lose consciousness, fall, and then start jerking and twitching. So we're going to talk about that in the stages of a seizure here as we go. The first stage, and not everyone has this, but the first stage is an aura. Some people, especially like people who suffer from epilepsy, which is constant seizures, constant tonic-clonic seizures, and that's what we're talking right now. The tonic-clonic is the name of the actual seizure that everyone suffers from. But some people have an aura. Some people, like in this picture, I put this picture up because they see like a bright white or bright spots. Some see rainbows or rainbow haze around everything. Some people have a metallic taste in their mouth. There's just different things. I can't tell you all of them, but people are like, uh-oh. And because of this aura, they're actually able to still drive and still be able to do normal functions because the aura gives them time to lay down, pull the car over, do whatever. But most people that do have seizure disorders don't drive or don't do anything that can cause other people harm, like take care of children, drive, stuff like that. So, but there is an aura. There is something like, it's like a warning sign that these people have, and they know they're having a seizure. And I've been with people saying, I'm seeing my rainbows again, or I've got that metallic taste. I'm probably going to have a seizure. So it gives you it's kind of nice. It gives you time to get ready to try to stop their seizure. So in a tonic-clonic stage, parts of the seizure itself, again, you have the aura, you may not. The tonic phase is basically where, and if you don't have the aura, they'll kind of scream out, ah, and they'll tense up, and they'll fall over. And they become extremely rigid. They'll tense up, and you'll see their back start to arch. They're just tense and tense and tense and tense. And then they'll kick over to the clonic stage. And that is where it's just the uncontrolled shaking, jerking, and irreversible movements. Now, keep in mind, these people are unresponsive. I picked up a guy out of the jail who was, quote-unquote, having seizures. And he was laying there jerking and twitching, and then he crack his eye open at me and go, hey man, I'm seizing. Like, okay dude, yeah, I see that. Yeah, you're seizing, buddy. You keep seizing. Okay. He was really seeking drugs. Because answer to this is going to be benzodiazepine, which is your Ativan, clonopin, stuff like that. It's the same family of drugs as the clonopins and stuff like that. So he was addicted to clonopins, knew that if he had a seizure, we used the benzodiazepine type medicine like Ativan, diazepam, stuff like that. He was wanting us to give him, he's basically looking to get high. So, and I obviously did not entertain him. When that's all said and done, your book talked about like a cessation of seizure stage or something. They added a new stage. That's basically when the jerking stops and the patient has not regained some sort of lucid level of consciousness. In that lucid level of consciousness, that's called the postictal state. I've always known it as they stop shaking, it's postictal from there on out. So it all depends on the book and the literature we're reading. I just wanted to throw that out there, but the slideshow didn't bring it in, and I didn't see it except for in the book, so that's the first time I've seen it. But it basically, postictal state is pretty much the body stops shaking, and they're going to start coming back. They're not going to be able to answer your questions. They're going to feel extremely tired. One of the things you have to realize is their body just jerked for however long and twitched and jerked. It was a complete electrical discharge. They tensed up, they jerked, they shook. They basically did a lot of activity in a very short period of time. So they're going to be extremely weak, extremely tired. They are going to be extremely confused. Sometimes they may even be combative, meaning that they're going to come out and they're pissed, they're mad. They may be taking a swing at you. So be very careful. But just know that is out there. That exists. Again, I threw this slide in here for you so you can see the different stages. Auras don't always happen. They can. But tonic, clonic, and the postictal states do. So they also talked about partial seizures. And these are seizures, and what I'm talking about right here. So you've got a generalized seizure, which is tonic, clonic. They have something called pseudo seizures. I really don't know much about it other than I think it's more psychological. I'm not really sure. They don't fake seizures, but it's not the normal firing discharge of the brain. I'm not exactly sure. So that's something that's new that's come out. But they do have something called partial seizures. You can have a simple partial where you have just one part of the body is just tremulating. You can have a complex seizure, a simple or partial complex. It was basically where the patient's sitting there talking, and then they'll stare off into space, and it's quiet, and you're like, what the hell just happened? And then they'll come right back, right where they left off. So there are those. Those are out there. But for us, what we're really concerned about is the tonic-clonic generalized seizures. These are all the common causes of it. One thing I want you to understand is there's a word called idiopathic. Idiopathic is basically, I don't know. I always look at it as like idiopathology, like idiotic pathology, because what does an idiot say? I don't know. I'm not sure. So that's what idiopathic to me means. But idiopathic does mean no known cause or origin. We don't know. We really, truly do not know what causes them. But here's all the things that can cause the seizure. It's important to recognize the seizure, look it over. One of the things that I will stress you not to do is do not shove anything down their throat. When people are seizing, they're actually not breathing. And yes, that's a bad thing, but they can go a few minutes without breathing. So they are not getting oxygen in. The best thing that you could do for a patient that's actively seizing in a home is try to move furniture out and away. Take everything that's around that patient and move it, and let them have that room to seize. Don't try to shove anything down their throat. I've seen that, been there, done that. Guy seizing in a car, show up, his mom would take, who's an idiot, didn't know, unscrewed a pin and put the plastic part with a hole and tried to shove it down his throat to get him to breathe. Well, now you just introduced something else into the body that we had to pull it out and then start trying to ventilate the patient. So please don't stick anything down there. Let the patient seize. The whole idea, the name of the game is you can probably put some oxygen on them if you can get it in and around their head. But the whole name of the game is to keep them from banging or hitting or further damaging themselves up against something else. And also, if they're still actively seizing, you put some oxygen on, that's great. It'll force the oxygen down. Hopefully you can get it down the alveolar space and start doing the gas exchange still. truly what you really want to recognize is the underlying cause. Now, they may have a history of it. They may have a tumor, something you can't do, but there are some things that you can do as far as like you can actually have somebody seize who's a diabetic with hypoglycemia. It can happen. So your job is to rule out what may be causing it, especially if it's new or unknown to this person to have seizures. Altered mental status, we've kind of touched on that. That's basically an unresponsive patient or a patient who is not alert and oriented times 3. The causes, basically we're talking about that. The hypoglycemia, hypoxemia means they're not getting enough oxygen into the bloodstream. Intoxicated, drug overdose. There could be an unrecognized head injury. That does happen. People fall, hit their head, or they're in a car wreck and bump their head, and they may have a small, tiny, minute bleed, and they don't know that. And they choose not to go to the hospital because, like, I'm fine. I don't want to go to the hospital, whatever. So that could be there, and all of a sudden it's built up to the point where now it's causing damage to the brain. So there's that. All right, syncope. Syncope is just another word for fainting. A syncopal episode is another word for somebody who passed out. And it's just because they have a temporary loss of consciousness. It could be a cardiac rhythm disturbance, dehydration. Sometimes people just have a vasovagal reaction, which is basically they trip their vagus nerve, which is one of the cranial nerves. They hold their breath or something, and they get super excited and they pass out. So that does happen. One of the things you do want to pay attention to is to make sure it's not from hypoglycemia, which is low blood sugar. Once again, could be a cause. And dehydration. People do get dehydrated. When you get dehydrated, your blood pressure goes down, and you need to give them fluids to kind of build their blood pressure back up a little bit. Headaches. Tension headaches. If people have tension headaches, it's usually from stress. What's happening is, and I'm sure all of you have felt stressed at some point in time in your life, or still feeling stressed. I feel stressed all the time. That you start having like your neck muscles and your shoulders are just tense and they're achy, and it winds up just contracting down and pulling, and it just causes you to have a headache. That's what a tension headache is. Migraine headache. A migraine headache is a headache that is global. Pain is global all over around the head, and it's just so severe. And it typically has to do with the blood vessels changing size. They constrict down, not letting enough blood flow and glucose in, or they dilate out and it's still not letting enough. There wasn't enough blood flow in there to keep up to match it. So either way, it's constricted down, vasodilated, open. The brain gets pissed off because it's a global thing. It's all around. One of the things that you'll find out that you give nitroglycerin, you can cause a headache and even a migraine headache because you vasodilated out that patient's vascular system. And that's one of the side effects of nitroglycerin is that they have a headache. Cluster headaches, they're typically usually in a group of the same area of the head, and they happen over time. That's why they're called clusters, because they'll have a headache, be okay, or it'll ease off, come back, ease off, come back, ease off, and then it stops. So that's why they're called cluster headaches, because these headaches are typically pinpointed into a certain area, and they cluster together of how many times you have them. So that's why they're called cluster headaches. All right, so your patient assessment, stuff that we're gonna talk about and go through your patient assessment right quick. So some of the things, again, oxygen, glucose. Your brain loves that stuff. When it stops getting that stuff, it gets pissed off, mad, and angry, and it's gonna do whatever it takes to try to get that back in there. Typically, it's gonna raise the blood, it's gonna raise your pressure to try to get the blood flow back in there for that. BSI, PPE. Your history is going to be your big clue. That's where you're going to find out. You're going to ask your sample, and we'll talk about that as we go. But that's it's going to happen. Posturing. All right. So if you have a head injury, again, this is stuff that we're going to learn in shock trauma, and we'll cover it again in shock trauma. But one of the things that you need to watch out for is if you do have a patient, especially with a bleed, they might start posturing. They usually start out decorticate and then they go to the cerebellum, if I'm not mistaken. And how I remember it is decorticate is holding the decort of liquor in my arm. I'm holding decort of liquor in my arm. And then cerebellum's the other one. That's the only way I remember how that goes. It's also called flexion because you're flexing towards your body, or extension because you're extending out away from the body. So those are some of the ways you can try to remember those. But that usually comes with head bleeding and head trauma. So you hadn't seen this yet. Again, I'm used to going over shock trauma first. Focus on your airway and breathing. Seizure patient, that's going to be very difficult to do. Stroke patient, absolutely. They may be having a stroke, but it might be that they actually have a partial blockage. There might be some blood flow still getting through. So load that hemoglobin in the red blood cell down with oxygen. Give them high flow O2. Obviously check your pulse. Blood pressure for some of these patients might be extremely high, especially your stroke patients. Transport decision. Obviously, these are probably going to be load and go patients. You're not going to dilly-dally around, especially if the patient is still seizing. If they're alert, find a chief complaint. If not, then altered mental status is their chief complaint, and it could be secondary to a seizure, stroke, whatever. Assess for injuries. We're gonna have to. We did not go over shock trauma first, so you did not do this first, but we'll learn about that. Obviously, get all of your stuff. GCS score. We're gonna have to talk about that. That's also in shock trauma when we talk about that. But GCS is usually typical of every patient. Emotional support. One thing I will tell you, patients having a stroke are typically, by nature, older people, and they are scared shitless. I told you, they still have useful function of their brain. They still, depending on where the blockage is, and they might be altered, but most of the time, it's the blockage is not too severe. They have a hard time talking, but they can still understand you, they can still hear you, and believe it or not, some good bedside manner goes a long way. So if you have these stroke patients, hey, listen, I know you might be able to understand me. We're doing the best we can. Talk to these people. Don't ignore them. Don't just keep doing your job. Talk to these people like, hey, listen, I know you could probably hear me, so this is what we're going on. Even if they're slightly altered, still talk to them. We talked about hypoglycemia, hypoxia. Hypoglycemia is you want to do the dextrose, which is your D50, which is your sugar. Glucagon that releases the sugar stores. We talked about that kind of it when we talked about the liver in our GIGU lecture. Keep reassessing your ABCs because things can change. Talked about the hypoglycemia, D50. You haven't learned about that yet. We'll get to that, I believe, when we get into endocrine. Stroke, oxygen, rapid transport. Get IV access. Keep the patient semi-Fowlers at least in case they do vomit and they don't aspirate because, again, they may not be able to control swallowing. So they may vomit and can't swallow back, or they'll vomit and then it'll start going down the windpipe, the trachea, and they'll aspirate it. It's bad stuff. That is a American Heart Association stroke care guide. I'll let you look at that at your own leisure. But TIA, you're going to find out that they're having a TIA. Still, again, the same thing with TIA. Stress transport. Don't let them refuse. Don't let them think that they're free and clear, that this is a one-time thing. Seizures, more than likely, if they're actively still seizing, you'll probably have to have a paramedic partner give medication, which is the benzodiazepines, to stop it. But the things that you can do is you can administer oxygen, try to get oxygen on their face. If you need to, suction because they could vomit or aspirate, or it is that they bit their tongue or some part of their tongue and they're bleeding and you don't want them to aspirate blood. IV access, you're probably not going to... You can get IV access, it's tough. But if you need to give the benzodiazepine, you can. And check a blood glucose. Syncope, the best thing you do for people who pass out and faint is, especially if you're going to transport them, it's called Trendelenburg position. Basically, put them on the stretcher, elevate their feet. Again, watch out for trauma because they may have hurt their back and they may not be able to tell you. Most of the time when you have a syncopal episode, though, by the time you show up, they're going to have some sort of level of consciousness regained because basically Syncope is where you're standing, your body says, hey, I can't do this anymore, lay down, damn it. And then the brain says, night, night. And then you fall, and basically your body's way of making you lay down. Headaches, you need to make sure it's not a stroke or going to progress into a stroke, but headaches is typically not much you can do for. Lights and sirens are bad juju. As far as a patient with a headache, another thing I want you to be aware of is that flashing lights can trigger a seizure. So if you pull up and leave your flashing wigwags on and your lights strobing, and you go into a patient's home and for a seizure and you bring them back out, it may be essential that you have to leave your lights on for visibility so another vehicle doesn't strike the ambulance. But be very mindful that you may need to get that patient in the back of the ambulance and then get those lights off as soon as possible. Also, bright lights. A patient may not be able to take or stand the bright lights, so be mindful of that. All right, so that's it. Any questions, let me know, and I'm going to send this up to you guys.